Hello guys, this is Dr. Ravindra Savarkar and I welcome you back to Med School. This is part 4 of the video series on chest x-rays. In this video, chest x-ray findings of abnormalities like pulmonary edema or ARDS, viral pneumonias, pleural effusion, pneumothorax, lung collapse and lung fibrosis will be discussed. The first topic of this video is pulmonary edema. Pulmonary edema can be cardiogenic, where there is raised pulmonary capillary pressure, or it can be non-cardiogenic, where there is increased pulmonary capillary permeability. As suggested by its name, cardiogenic pulmonary edema is mostly due to cardiac causes like LV dysfunction or valvular dysfunction. But sometimes intravascular volume increases to such an extent that the normal heart is unable to handle it and leads to congestive cardiac failure and pulmonary edema. Examples of such situations are kidney failure, severe anemia, etc. You must be thinking if it is possible to differentiate cardiogenic and non-cardiogenic pulmonary edema on chest X-ray. Answer is yes. Findings that support cardiogenic pulmonary edema are cardiomegaly, curly A and B lines, perihilar and basilar infiltrate, and presence of bilateral pleural effusions. This is the chest X-ray of the patient presented with breathlessness. In this X-ray, bilateral, perihilar and basilar infiltrate can be seen. Also, the cardiothoracic ratio appears to be more than 0.5, which indicates cardiomegaly. I hope you have watched part 2 video of this series, where cardiothoracic ratio is discussed in details. Moreover, blunting of both the cardiophrenic angle can be seen, indicating presence of bilateral pleural effusion. Curly A and B lines are also visible on closer look. So this chest X-ray represents cardiogenic pulmonary edema. You must be wondering how I can look for curly A and B lines even on closer look if I don't know what they are exactly. Don't worry, here is the explanation. On this closer look, curly A lines are the linear opacities extending from the periphery to the hyla, caused by distension of anastomotic channels between peripheral and central lymphatics. Whereas curly B lines are small horizontal peripheral straight lines demonstrated at the lung bases that represent thickened interlobular septa. Non-cardiogenic pulmonary edema is commonly called as acute lung injury or acute respiratory distress syndrome, depending on PO2 to FiO2 ratio. Let's see how it differs from cardiogenic pulmonary edema. So, differentiating features are its diffuse location, absence of cardiomegaly, absence of curly A and B lines, and pleural effusion is uncommon in non-cardiogenic pulmonary edema. But I want to emphasize here that none of this differentiating feature is absolute. So one need to take patient's clinical profile, 2D echocardiography and other lab investigation results into account before making this differentiation. On chest X-ray, viral pneumonia initially presents as poorly defined nodules, patchy areas of peribronchial ground glass opacities, and hyperinflation, which occurs due to associated bronchiolitis. Here, hyperinflation can be guessed from flattened domes of diaphragm. On the progression of viral pneumonia, there is the appearance of homogeneous patchy airspace consolidation and ground glass opacities. You must note that differentiating cardiogenic and non-cardiogenic pulmonary edema and viral pneumonia is very difficult only on chest X-ray. Hence, clinical correlation in such cases is very important. Pleural effusion is nothing but a collection of excess fluid in pleural space. As you must know, 10 to 20 ml of pleural fluid is present normally. Anything more than that can be considered as pleural effusion. But the first sign of pleural effusion on X-ray appears on lateral decubitus film when there is around 50 ml of pleural fluid. Here, effusion appears as linear shadows separating ribs from the lung. Unfortunately, I don't have a good lateral decubitus X-ray explaining this, but I will post a link for the same in description. On PA view, the first sign of pleural effusion appears as blunting of costophrenic angle, which appears when pleural fluid quantity is more than 200 ml. To understand CP angle blunting, first have a look at this normal X-ray. Normal CP angle appears like this. Now look at this X-ray, where both the CP angles are blunted. Now you can clearly understand the difference. The upper border of pleural effusion is not straight line, but a curved in concave upward direction. This is called as Ellis S-shaped curve or meniscus sign. As the amount of the pleural fluid increases, the upper border of pleural effusion shifts upward, along with the blunting of the cardiophrenic angle. A massive pleural effusion also pushes mediastinum to the opposite side. If mediastinum is not shifted to the opposite side even with massive pleural effusion, then there can be two possibilities. When the underlying lung is collapsed, it exerts a pull on mediastinum, which counters the push of pleural effusion. Or it can be a malignant pleural effusion where shift is prevented by local tissue encroachment by malignant mass. Pneumothorax is defined as air in pleural cavity, that is between visceral and parietal pleura. Radiological diagnosis of pneumothorax is made on the basis of presence of pleural line, that is line between visceral pleura over lungs and air in pleural cavity. In this X-ray, this is the pleural line. Pulmonary vasculature markings are absent beyond this line. On PA view, that is erect posture, pneumothorax is seen prominently near apical area because of the natural tendency of the air to be collected at the highest point. But more often than not, patients with pneumothorax are unable to stand. So PA view is difficult to obtain. So on supine chest X-ray, sign of pneumothorax are prominent in juxtacardiac, lateral chest wall and subpulmonic area. Like in this X-ray, pleural line is near to lateral chest wall. Sometimes, only sign of pneumothorax on a supine X-ray is deep costophrenic angle, which is also called as deep sulcus sign. Like in this X-ray, left CP angle is so deep that it is not even completely visible in this film. Sometimes, pneumothorax increases to such a level that it starts to compress the heart and major blood vessels, which leads to circulatory compromise and shock. This is called as tension pneumothorax. On chest X-ray, sign of tension are mediastinal shift and flattening of dome of diaphragm. I want you to note that diagnosis of tension pneumothorax is made on clinical grounds. Presence of these X-ray signs can help in making the diagnosis, but they are not absolute. That means tension pneumothorax can also be there without these signs. When suspicion of pneumothorax is high but normal inspiratory film is not showing pneumothorax, then chest X-ray should be repeated with full expiration and in lateral decubitus position. Sometimes some artifacts like skin fold, medial border of scapula or catheter may mimic pleural line and findings can be confused with pneumothorax. Like in this X-ray, medial border of scapula can be confused with pleural line. But pulmonary vasculature markings are present on both sides of false pleural line. Hydropneumothorax is nothing but the combination of fluid and air in pleural space. That is, it is a combination of pleural effusion and pneumothorax. Both these entities changes presentation of each other on chest X-ray. In case of pleural effusion, upper border is a straight line instead of a curved line. But like pleural effusion, CP angle is blunted in hydropneumothorax also. In case of pneumothorax, Pleural line is seen in most of the cases. But deep sulcus sign is not seen as CP angle is already blunted due to pleural effusion. We can get this classical presentation only if X-ray is taken in an erect position. There are two types of lung collapse. Complete lung collapse, which occurs in pneumothorax, massive pleural effusion, etc. and lobar collapse, which occurs in pleural effusion, tumors, and lobar bronchus obstruction, etc. There are some common features to both complete lung collapse and lobar collapse. As a collapsed lung occupies less volume, pulmonary vessels appear crowded. Collapsed lung exerts a pulling force on surrounding tissues. So, pull on diaphragm causes elevation of ipsilateral hemidiaphragm. Pull on ribs causes crowding. Pull on mediastinum and hilum causes their displacement towards collapsed lung or lobe of lung. Normal lobes or lungs hyperinflates as a compensatory mechanism. The most common cause of complete lung collapse is pneumothorax. In the cases of pneumothorax, one can easily see the collapsed lung. Whereas massive pleural effusion can also cause complete lung collapse. But it is difficult to appreciate it as in this X-ray. Here, the right CP angle is blunted, suggesting the presence of pleural effusion. Normally, pleural effusion should push the mediastinum to the opposite side. But in this X-ray, trachea and heart shadow both are shifted to right. This shift is due to pull exerted by an underlying collapsed lung. In lobar lung collapse, changes are confined to the area of particular lobe, and there is peculiar shifting granuloma sign. To understand this, let's consider a chest X-ray having a granuloma. Now, if one of the lobe on the same side gets collapsed, this granuloma will shift toward the collapsed lobe. This is the shifting granuloma sign. Also note that this sign is not limited to granuloma only. This is applicable to any other lesion. Individual lobes can also collapse due to external pressure or blockage of lobar bronchus. Along with the common features, each lung collapse has specific X-ray features also. In the right upper lobe collapse, the upper part of the mediastinum is pushed toward right. The lower border of the collapsed upper lobe appears like an inverted S. This is called as the golden S sign. In the right middle lobe of lung collapse, main X-ray feature is hilar displacement toward the collapsed lobe. In the right lower lobe collapse, there is a triangular opacification in right lower zone. This opacity obscures the right hemidiaphragm. Right hilum is also pulled inferiorly towards the collapsed lobe. In the left lower lobe collapse also, there is a triangular opacity in the left lower zone. The lateral edge of this opacity may create a double cardiac contour. The left hilum is also pulled inferiorly towards the collapsed lobe. Lung fibrosis is the presence of excessive connective tissue in lung interstitium. This leads to distortion of normal anatomy and defective oxygenation. On X-ray, lung fibrosis presents as reticular shadows, traction on surrounding structures, and honeycombing, which is nothing but the presence of cystic air spaces with thick fibrous walls. Sometimes fibrosis involves limited area, such as only one lung or one lobe, etc. This chest X-ray shows reticular shadow in right lower zone. This suggests fibrosis in right lower lobe and maybe some part of right middle lobe. There is mediastinal shift toward right due to traction of fibrous lung tissue. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, Please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.